This is NNI Bites, Big Learnings, a podcast where fellow healthcare professionals converse about the latest on nutrition science. Join us as Joseph Noe and Catalina Bazacliu share their knowledge and insights on individualized nutrition for infants with bronchopulmonary dysplasia.
Hello. Welcome to Nestlé Nutrition Institute's special podcast, NNI Bites, Big Learnings. I'm your host today, Joseph New, and I'm a professor of pediatrics and neonatology at the University of Florida in Gainesville. I am joined by Catalina Bazacliu, also from the University of Florida, and she also specializes in neonatology and has a very special interest in chronic lung disease and bronchopulmonary dysplasia in neonates. And I'd like to have Catalina introduce herself and tell you a little bit about her credentials and her background.
Thank you, Joe, for your kind introduction. I am Catalina Bazacliu. I am a clinical associate professor of neonatology here at University of Florida.
So thank you, Catalina. BPD is a huge problem in neonatal intensive care. And a lot of attention has been paid to mechanical ventilation and oxygen, but I think that we are beginning to recognize more and more how important nutrition is for this problem. And so, from a historical perspective, could you tell us a little bit about some of the nutritional factors that have been found to be important for optimizing nutrition for infants at high risk for developing BPD and who have existing BPD?
The goal in preventing BPD first is an optimal growth and especially preventing a growth failure postnatally. There is a wealth of data now showing that growth failure at anywhere between 4 and 12 weeks after birth is associated with increased risk of developing bronchopulmonary dysplasia. There are a few things that prove to be important. One is the fluid management. The babies that received a lot of fluid at the beginning of life have an increased risk of developing BPD. The caloric density of nutrition matters, and not only in the total amount of calories, but also their source. It's important. There are studies showing that nutrition rich in carbohydrates may increase the risk of BPD. The lipids are important as a caloric source, and the quality of lipids with specifically focus on the lipids that modulate inflammation, like polyunsaturated fatty acids. Proteins are important as we learn that those babies need a significant amount of proteins for growth, especially for length growth. But an appropriate calorie to protein ratio is also important. A low calorie to protein ratio, so that would mean a higher amount of protein than needed, can also increase the risk of bronchopulmonary dysplasia. Now, there are a number of other what we call micronutrients that were highlighted over time it was hoped that they may aid in mitigating this disease. Vitamin A, it's probably the most notorious of them. There were some studies showing that vitamin A deficiency is associated with increased risk for BPD. So supplementation of vitamin A post-birth was found to decrease a little bit the risk of BPD. Now, to my knowledge, there are still places that use it, but most of the units, at least in the United States, do not use it anymore. Vitamin E was proposed for its antioxidant effects, and vitamin D became more studied um, for its potential effect in preventing BPD, probably due to its effect of preventing wheezing in infants and small children. There are other components found in breast milk, for example, that could be important, such as oligosaccharides. Um, for established BPD, things are a little complicated. Many times those babies have growth failure, and it's really hard to maintain growth in infants who have a significantly higher caloric need, that it's really sometimes difficult to meet. Also, those babies many times needs fluid restriction, and they are also subjected to a lot of therapies that do not help growth. And by this, I understand steroid therapies, diuretics. So it's really a fine balance between the caloric needs and compensated for a very poor growth. One of the things that I found very helpful is optimizing the respiratory support in order to decrease the caloric needs, the caloric expenditure in the babies with the established BPD that do not grow.
One of the things that we have in neonatal intensive care is this concept that babies can grow quite well if you just give them parenteral nutrition. But there's also a huge role of the gastrointestinal tract in terms of down regulation of early inflammation. And could you talk a little bit about that role of enteral nutrition and how this may relate to prevention of bronchopulmonary dysplasia?
There is actually data showing that a higher percent of enteral nutrition in the first week or 2 weeks of life is associated with a decreased risk of bronchopulmonary dysplasia. I think enteral nutrition it's very important in any baby, at risk or not at risk for bronchopulmonary dysplasia for this matter. One of the benefits of enteral nutrition is ensuring an appropriate or as normal as it can develop in a neonatal intensive care unit microbiome. And we have enough data from animals now, at least, to understand that an altered microbiome, it's promoting inflammation. And inflammation, it's one of the things that causes and contributes to a more severe type of disease. We have in neonatology, at least in some places, we have this idea that if we don't feed the gut or feed the gut later, we will prevent some gut injury, like maybe necrotizing enterocolitis. I don't think that I don't think that data supports that. I think that cautious feeding and Ideally, feeding with maternal breast milk when available is more beneficial than a prolonged course of parental nutrition. We also sometimes have a tendency, because some of those babies are very sick and very unstable, we have a tendency of stopping enteral feeds and putting them on parental nutrition at the slightest sign of instability. Um, and I don't think this is long term, this is probably not beneficial, but of course, we need to prevent other complication as much as we can. Um, maybe one interesting component of breast milk would be the oligosaccharides as prebiotics. And I think it's very important for babies to receive breast milk, to try to establish a better microbiome and for bioavailability of nutrients. Um, Another downside that parenteral nutrition has is the component, the lack or the amino acid component, the lack or of carnitine, and there are some amino acids that are important in nutrition and they are probably important in modulating inflammation, and they are important as antioxidants. One of them is carnitine, that it's promoting fatty acid oxidation, especially in the setting of hyperoxia.
This is wonderful, Catalina. I think that very important information in terms of the enteral nutrition and some of these specific nutrients. Now, in the future, I think that there's a lot of emphasis now being placed on precision nutrition and the role of artificial intelligence and machine learning on precision nutrition for the future. How do you see that playing a role in the prevention and treatment of BPD?
Thank you for this question. Um, I think we coming from historically, we treating patients first through observations, and then we have like a series of patients, and those that respond to a treatment or to an intervention. And based on that, we creating clinical hypotheses that sometimes we're testing in the lab, sometimes we're testing directly clinically. Um, and we creating those randomized controlled trials, which is the best way we have available to determine if an intervention is working or not. The problem with those trials in neonatology specifically is that in order to have enough patients, and because of our ability to select patients, we applying it to a cohort of babies. So for example, the babies that are most at risk for bronchopulmonary dysplasia are the one born at less than 28 weeks gestation. Um, but uh, that includes 28 week, 27 weeker, 27 and 6 day baby born at 27 and 6 days, whose risk of developing BPD is significantly lower than, let's say, for a 23 and 0 days babies. So we clumping all those babies together and try to figure out if an intervention is working or not. And many times, because of the population, it's so has so diverse, such a wide range of physiology, we do not find any significance. And even when we find statistical significance, does that make a difference clinically? From there, we're trying to look at, because we know the physiology is different, we start to look at subgroups. So we're dividing this population into the, let's say, 22, 24 weekers and 24, 27 weekers. And we try to figure out if the intervention worked in any of those groups. Now we're losing the power, of course, when in doing this. So I think we missing babies in which an intervention can work because of those clumping together. So artificial intelligence, learning, machine learning, and has the ability to better cluster, of course, based on clinical information that we're providing, to better cluster those babies. So we can select to apply an intervention on a population that it's at a higher risk of developing a disease or having a disease. So we have a better chances of understanding if it's working or not on a population with a higher risk for that particular problem. I think that artificial intelligence would really help us eventually individualize nutrition. And whether it's going to be done using, for example, a digital twin or in other ways that are yet to be developed, is to be determined.
So, Catalina, thank you so much for these very interesting viewpoints. And perhaps you could just summarize what you consider to be some of the most important points from this episode.
Sure. So bronchopulmonary dysplasia is a disease that in which prevention is extremely important. Our intervention and our nutrition early in life is could contribute to the development or its prevention. So I would say very careful fluid management and optimal nutrition, optimal calories, and preventing growth failure in those baby is one of the most important things. The second most important thing is enteral nutrition. And enteral nutrition, preferably with maternal milk. The third would be use all the non-nutrition intervention that can actually promote growth and decrease the energy expenditure, like respiratory support, avoid medications that are affecting growth whenever is possible.
So synergizing our therapeutic strategies and certainly including nutrition as a very important component of this appears to be what is a very important factor here. So I think we have to close here, and thank you, Catalina, for sharing your experience and knowledge with us. And also thank you to the listeners, and we hope that you enjoyed this episode.
Thank you very much, Joe, for inviting me. It was a pleasure, and thank you to the listeners.
And that concludes today's episode. Thank you for joining us with Joseph Noe and Catalina Bazacliu as we talked about individualized nutrition for infants with bronchopulmonary dysplasia. We hope you enjoyed and learned from this quick discussion, fellow experts. Till the next episode.